Okie dokie. All right, and then I'm going to try and share my screen, which is always the challenge. Okay, awesome. Can everyone see that?
Yes.
Awesome. All right, so I'm going to be sort of letting people in who are still arriving, but if everybody's happy for me to get started and lose my train of thought, then we'll do it that way. Okay, so I've thrown IMHA, immune-mediated haemolytic anemia. I've thrown immune-mediated thrombocytopenia in there because a lot of the kind of theories and things are the same. And I've thrown this in there because I've just had a patient this week who's relapsed to IMHA for the 3rd time this year. And this time it's got IMTP as well. And that's how I feel about the whole kind of group of immune-mediated diseases currently. So we're just going to go through some diagnosis and management. There's been, does everybody know about the ACVIM consensus statements? It's the American College of Veterinary Internal Medicine. They basically get all of the experts, the people that publish on diseases commonly, all together and get them to come to a consensus and agree on sort of a subject. And there's been recently one on diagnosis of IMHA and another one on management of IMHA. So what we're sort of going to be talking about is what I do and then what the experts say you should do as well. And this diagnosis paper, they sort of go through what evidence we have for saying that IMHA is triggered by different diseases. So in practice, who's seen IMHA patients? Yeah. It's pretty common. I mean, it's a rare common disease, but it's not super rare. I think most clinicians have dealt with at least one patient, if not several. And if not dealt with them in the initial period, dealt with them in the sort of monitoring phase. And what is sort of in the back of your mind as potential triggers for IMHA?
Any kind of infectious source or inflammatory response to something?
Yep, excellent. And I know I've got the list on the screen. Like there's.
Yeah, well, basically that's it. Yes.
Exactly. So we tend to think of IMHA as either being primary, which is basically just means we don't know what triggered it, and that the assumption is that it's a genetic disease that was triggered by something in the environment, which we'll never get to the bottom of. And then there's secondary to something, and in this consensus statement they decided to call it associative, so associated with something. And the only reason they've changed that is because secondary implies that medication caused this, and associative implies that you got IMHA sort of time frame wise close to when this happened, and not necessarily kind of saying that this caused this, but these two syndromes or diseases or drug and disease go together. But essentially the way I think of all immune-mediated diseases is that dogs have a genetic predisposition for them that they're born with, and then something in the environment triggers that genetic predisposition to trigger an autoimmune disease. So there's a sort of a lot of evidence for the genetic side of things, and it's just the environmental side that we don't really understand, and that probably varies a lot from dog to dog. So primary or secondary, and the things that we sort of think of as the triggers of IMHA, or that we have historically thought of as the triggers for IMHA, are infections. So obviously infections trigger the immune system, and there's an opportunity for the immune system to kind of overreact in response to them or react incorrectly. And by far the most common infections that we see are cystitis and pneumonia. And that's kind of important because it dictates the testing that we do in the sort of diagnostic phase. There's certainly historically been drugs implicated in triggering IMHA, so particularly the cephalosporins and beta-lactam antibiotics, which we use all the time. That link is more documented in humans, and we actually don't have very good evidence for it in animals. But because none of the case studies are big enough to really kind of draw conclusions, we I guess if I've got a dog with a history of CLAB in the month before developing IMHA, then I'm probably not going to let them have CLAB again over the rest of their life, just in case. Certainly neoplasia is a big cause of IMHA in cats, I will say. So cats are more likely to get, I guess, lympho type diseases, which particularly will alter the way that antibodies are produced and alter the immune responses. In dogs, there's like single case reports and things where it's associated with certain carcinomas, but there's not a whole heap of evidence that cancer causes it. And I think one of the things in our screening that we're doing, we often do an ultrasound. We're often looking for splenic pathology as the cause of IMHA. And probably what we're dealing with, if there's a splenic mass, is red cell damage as the red cells pass through damaged blood vessels within the spleen, or aberrant macrophage or reticular endothelial kind of filtering of the red cells. And it might not actually be a true IMHA if there's a splenic neoplasia. It might be more of a kind of physical damage of the red cells. So it's important to differentiate whether it's immune mediated or not. Inflammatory diseases, I don't think I've ever seen IMHA associated with pancreatitis. Jeff, what's your feel on that?
I suppose the most honest answer is no comment, because I don't have any memory of associating it. I'm just trying to think back as you're talking the cases I had seen, and I just don't remember any particular link in any of them, actually.
Yeah, me neither. IMPA, I mean, any other immune-mediated diseases, we're kind of acknowledging that this dog's got deranged immune responses, and I don't think that IMPA or Evans syndrome are triggers of IMHA, because IMHA is a component of Evans syndrome, but definitely a dog that is prone to an autoimmune disease of one kind is susceptible to other kinds as well, as I'm seeing with my patient that's in this week. And vaccination.
Anna, what does IMPA stand for?
Immune-mediated polyarthropathy. So obviously polyarthritis in the joints. Vaccinations, what's everybody's kind of, does anybody have a spiel that they talk to clients about when they're suspicious of IMHA, or do you vaccinate patients that have had IMHA previously?
I'd asked them when they were last vaccinated, but I think I might have found one within 2 months in the past, but mostly no.
Yeah. Because essentially I feel like you sort of go through this list, and anything that triggers the immune system to react could potentially trigger an autoimmune response in a susceptible individual. And that might be the environmental trigger, but it's not necessarily, it doesn't necessarily mean that vaccines are bad or that CLAB is bad. It just means that in this dog, it was waiting for something to set it off, and that was just happened to be the thing. But then whatever set it off the first time is likely to set it off subsequent times, and therefore should be avoided lifelong. Vaccinations, there's been a big study to look at incidence of immune-mediated thrombocytopenia and IMHA secondary to vaccinations. And what they were looking for is a vaccination to have occurred in the month prior to IMHA developing. And there was no increased sort of rate of vaccination in the month in the lead up to development than in dogs with IMHA and IMT. So essentially discounts that link. But again, I do think that anything that triggers the immune system is an opportunity for a primed immune system to then tip into an autoimmune disorder. I think I've opened the wrong slideshow, but let's do a case anyway. So the ACVIM consensus statement has gone through some really good, there's an algorithm in the diagnosis paper, which just says these are the things that you need to demonstrate to make a diagnosis of IMHA. if you're missing one of them, do this. If you're missing one of these, then do this. And it really helps to kind of make your diagnosis as kind of slam dunk as possible. And this is a pretty slam dunk case, but it presented with a very astute owner and before it was actually anemic. So this is a dog, Ruby, who's a 4-year-old female neutered Jack Russell Terrier. And knowing what we're talking about, it's not a mystery what she's going to be diagnosed with. So we'll talk about her signalment now. IMHA is most common in middle-aged female dogs. So sort of any time that you've got a sort of, you're not sure whether you should go down the pathway of looking into whether it is IMHA, that signalment should sort of add weight to an argument of pursuing diagnostics. Ruby had a 2-day history of lethargy and anorexia, and she had a mild pyrexia. Does everybody sort of, have you seen pyrexia in your immune-mediated disease patients? Yeah. So it's really, really common. These diseases are profoundly inflammatory, and essentially the body thinks it's fighting a really serious infection. So the body's response to IMHA is the same as the body's response to a terrible cystitis or sepsis, essentially. In-house, Ruby's PCV was actually still normal at 35%, and her TPP was nice and high, so 72. Anytime we see a TPP, I'm going to ask you guys actually, what when you're trying to differentiate loss of red cells versus loss of whole blood, so bleeding versus hemolysis, what sort of TPs are you looking for? Do you have a kind of a range in the back of your mind that you're comfortable with?
No, I don't. I just go on, I won't say gut feeling, but brain feeling, I guess. Just that whether they seem to be falling in sync or not.
I agree, and I actually presented this talk with Lucy Curtin, and she's really she's a criticalist at, she's not a specialist, but she's done a lot of critical care work with NEVs. And she was talking about transfusions in conjunction with this talk, and she said, if the TPP is under 50, it is not hemolysis, it is bleeding, and you need to act fast. So that was a really good kind of cutoff for me, because quite often you see them kind of 60, it's not very high, but it's not very low, could be either. And it's really nice for me to have 50 definitely bleeding, and then anything above that could be either bleeding or hemolysis. So I sent Ruby's bloods out to the reference lab for them to give me some information on what her red cells were doing, why she was pyrexic, whether she had an inflammatory leukogram, all of the rest of it. But I was pretty nervous with her because I drew the EDTA, and as I was writing the lab request form, the EDTA was agglutinating in front of me. So it was a bit of a indicator that we were in for some trouble. So 24 hours later, I got her back in, and her PCV had dropped to 27 by 24 hours later. And the most kind of notable thing here is that her TPV was exactly the same as it had been the day before. So I know that she hasn't lost blood. I know that she's only lost red cells because she's still got the same amount of protein in her system. So when I'm looking at one of these patients clinically, I'm looking for kind of subtle things that you aren't necessarily on the list of diagnostics, but things like if I do a PCV and I see that the serum is haemolytic, then I'm concerned, even if sort of before they've even developed an anemia, that in the phase of being unwell, but before the anemia develops, if the serum is either haemolytic or icteric, then I'm concerned that we've got some red cell destruction going on. As I mentioned, if their EDTA tube you pull is agglutinating, that's very suggestive of an autoimmune IMHA. We often do ultrasounds in unwell dogs just to investigate them, and particularly a lot of these dogs have a palpable splenomegaly, and you want to differentiate neoplastic versus kind of reactive splenomegaly. So the things that I would look out for on an ultrasound is the size of the spleen, and obviously the whether there's a mass present or any other sort of neoplasia present. Who does ultrasounds? I know Jane and Josh have seen a few. Pretty much every single patient I've ever scanned with IMHA looks like sort of smoke. The blood moving through their caudal vena cava looks like smoke. And it's because red cell agglutinate, so red cells stuck together, reflect more sound waves than a single red cell on its own. So blood should look just black. So when the blood's agglutinated, it looks echogenic. So that's something, an early hint that we get that the blood cells are sticky. Pyrexia, obviously, as we talked about, obviously the PCV in-house. And obviously, you know, you get your CBC back, they might be kind of bordering on anemic or not quite anemic yet. Look at the reticulocyte count. Should IMHA be regenerative or non-regenerative?
Usually regenerative.
Regenerative, yeah.
Absolutely. Yeah, so we should have a reticulocytosis, but there's two scenarios where we don't. And that's if the IMHA is quite acute in onset and the bone marrow hasn't been stimulated enough to produce or excrete reticulocytes yet, or if this is one of the IMHAs which is actually directed at reticulocytes or red blood cell precursors, which means that you won't get a regenerative response. And at diagnosis, 30% of dogs are non-regenerative. So if you're looking at your CBC and going, could it be IMHA and it's non-regenerative, don't rule it out. Just keep it on your list. And the other thing on your CBC, this is why it's really annoying to have a prolonged turnaround time in a patient that you're worried might be developing quite an acute disease. But the pathologist reports are so valuable with red cell morphology in these patients. So looking for a whole heap of things that we'll go through later in the talk, but the presence of spherocytes is probably my number one. And you need to have taken the CBC that's sent off to the lab before you do a transfusion, because transfusion you'll get a lot of kind of dying red cells. You'll get a lot of red cells that have been traumatized going through a catheter and abnormal shapes. And after transfusion, spherocytes are actually expected. So even in normal patients, so, you know, hit by car patients will have spherocytes after a transfusion. So it makes it a lot harder to get those kind of subtle hints out of your CBC if you've sent the blood off after transfusion or after kind of immunosuppressant start and things. Now, the quality of this picture is absolutely terrible, but I'm really happy to email around or post a link with the kind of rounds video of these papers, so you've got a copy of these algorithms. But this is essentially what the consensus statement says, is that to get a slam dunk diagnosis of IMHA, you have to have greater than 2 signs of immune-mediated red cell destruction, which includes spherocytes, a positive saline agglutination test, a positive Coombs test, direct antiglobulin test, or a positive saline agglutination test that persists with washing. So you've got to have two or more of these signs for a slam dunk. And so yes, you do have those. Then you've got to have greater than 1 sign of hemolysis as well as that. So you've got to have either hyperbilirubinaemia or bilirubinuria if your owners don't want to go with biochem, or you haven't done a biochem, bilirubinemia, oh my gosh, I'm going to skip that word. You know what I mean? In the urine. And icterus on clinical exam are really good indicators of hemolysis. And then haemoglobinaemia, which we'll talk about a lot more later on, about why that happens and how much to sort of read into that, and concurrent hemoglobinuria. And then erythrocyte ghosts, which is something that came up in this consensus statement, but I have to say wasn't really on my radar to look for before this. And we'll show some pictures of what to look for if you're doing smears in-house and stuff. So if you've got those 2 things, then you've got a slam dunk diagnosis for IMHA. If you've not got one of those, it's got all the different scenarios of, you know, what to do, what test to do, and what to do next in the consensus statement, but we're kind of just going to go through how to recognise all of these. So you want to document immune-mediated destruction and hemolysis. So if we go through first the signs of immune-mediated destruction, is everybody, who does smears and looks at them themselves? You do? So I'm going to go through why spherocytes develop. So this is a normal red blood cell. Red blood cells are discs which have a flat portion in the centre, and all of the kind of the guts of the red cell sit around this periphery. When you're looking at them under the microscope, you see the dark round bit and the white part in the middle, which is the flat part, which doesn't have a whole heap of guts in it. Now, when you've got IMHA, you get, I'm going to see if I can draw here actually, you get antibodies adhering to the membrane of your red blood cells. Now, as that red blood cell goes through the spleen or in circulation, that antibody is like a flag to the immune system to destroy that red blood cell. There's something wrong with me. You need to take this up into a macrophage and filter it out for me. So as this red blood cell goes through the spleen, the reticular endothelial cell takes a bite out of it to sample it. So it takes a sort of chunk out of the membrane, or I should say on the antibody one, takes a chunk out of the membrane. It only takes a chunk out of the membrane, doesn't take any of the guts out. And that membrane then has to close, a smaller membrane has to close around the guts. So all the guts get pushed into the middle of the red cell and the red cell turns round instead of disc-shaped. The actual spherocytes are much smaller diameter, right, when you look at them. But the actual volume in the cell is exactly the same as that. So your MCV, mean cell volume, will be normal if you've got spherocytes. It will be high if you've got reticulocytes because they've got more guts. Does that make sense to everybody? Yeah. And as we talked about with transfusions, stored blood cells, sorry, I'm going to sneeze. Sorry. Stored blood cells, so blood transfusion products, have a much higher proportion of spherocytes. And we see immune-mediated sampling of transfused blood within the patient after a transfusion. So blood taken after a transfusion is significantly more likely to have spherocytes. Sorry, everyone. Okay, so the next sort of evidence of immune-mediated destruction is the saline agglutination test. Who does these in clinic? Yep. Everybody? Great. This is such a useful test to detect whether you've got antibodies on the surface of your red cells. I'm going to try and draw you another picture. It might be bad. So the reason why red cells agglutinate with antibodies on their surface is that the antibodies actually like to stick together. Oh, that's a terrible antibody. These bonds between antibodies are nowhere, so red cell, antibody, and then the antibodies stick together, and then red cells. So you see microscopically a clump of red cells, obviously you can't see the antibody, but it's the antibodies holding them together. The bonds between antibodies are actually quite weak. They're nowhere near as strong as a clot. So as this is moving through circulation, they get knocked apart, they stick together, they're knocked apart, stick together. So it's not this that causes thrombosis or infarction or anything in IMHA, but outside of the dog where it's not being knocked apart, stuck together again, we can see them sticking together pretty convincingly. So the saline agglutination test, the technique used in the consensus statement is 1 drop of blood with 4 drops of saline, and that's EDTA blood. You want it anticoagulated so you're not getting any clots that look like agglutinates. 1 drop of EDTA blood, 4 drops of saline has a much better sensitivity than 1-to-1, which is what I traditionally did. So that was a nice change for me. And the recommendation is that if you see rouleau, you should wash the erythrocytes. Now that sounds really tricky, if you take your EDTA tube and you put it in your centrifuge on a urine sediment setting, and then you take the red cell sediment down to the bottom, and you take the kind of supernatant off, and then you add saline and mix it all up again, and then you put it back in your centrifuge on the urine setting, spin it again, and you take the saline off. The cells settle to the bottom, take the saline off, and then you add saline again, and then you spin it again, and you take the saline off. That's what washing erythrocytes is. So it's not like you have to sort of get your scrubbing brush out and clean every one of them or anything like that. It's actually a really simple thing to do, a bit time consuming, but if you show your nurses once, they'll be able to do it for you in future. So if you're seeing real low, or if there's a very high total protein, because that causes things to be a bit sticky in there, or if you've got high fibrinogen, then you should wash them. So they're the three scenarios. We don't really routinely test fibrinogen levels, so that's kind of hard to know, but you can predict that any dog with an inflammatory disease will have a high fibrinogen level. That's one of the acute phase reactants. So if you've got a dog with, for example, concurrent infection that you know about, or pancreatitis, you can bank on that they've got high fibrinogen, and you should probably wash the erythrocytes so that they're not stuck together with all that sticky fibrinogen. So this is what this actually looks like under the microscope. Excuse me. Picture A is a picture of rouleau. This doesn't count as agglutination. Cats have rouleau normally. Dogs have it with certain disease states, but it's not actually agglutinates. So if you're seeing this under the microscope, then go back, wash your EDTA cells and do it again. This is agglutination under the microscope. And the previous slide, you saw the gross agglutination. If you're seeing agglutination under the microscope, this is what it looks like. If you're not seeing it grossly, have a look under the microscope, because if there's less antibodies, there's less clumps. The clumps are smaller and you won't be able to see them macroscopically, but they will be evident microscopically. Any questions on that?
Yeah, and does that mean if you've got a lot of rouleau grossly, you'd probably see similar signs?
Similar signs.
Then, like, you'd see that kind of clumping grossly before you wash them?
You actually probably shouldn't see it macroscopically. Rouleau should only be microscopic. So the kind of mechanism of clumping in rouleau means that the clumps should never be big enough that you'd see them macroscopically.
Cool. Awesome.
Okay, so the next thing we talked about, saline agglutination test, now doing a direct antibody test, which is called a Coombs test, which most of us call it. Does everyone know what a Coombs test is testing for? Sort of, no?
Is it for the antibodies?
Yeah, exactly. So the Coombs test adds antibodies that are directed against these antibodies to a sample. So if you've got antibodies on the surface of your red cells, then these antibodies are going to stick to them and they're going to fluoresce, or whatever technique the lab is using to detect that these antibodies are stuck on there. There's a lot of false negatives. So we call it a sort of moderate sensitivity test. So if there's not a lot of antibodies, or if the antibodies came off with washing, we'll get a negative. But a positive test is diagnostic. So there's not really any false positives in this test. So if we get fluorescence, if these antibodies stuck to something, it means that there's antibodies on the surface of our red cells. So you can imagine if you've started immunosuppressants, you've got less antibodies present, you make the sensitivity of this test lower. This test can be done retrospectively on the sample that you submitted to the lab on the first day because you wanted to know what the red cells were doing in a smear. So if you submit that pre-transfusion, pre-immunosuppressant sample to the lab, it comes back with spherocytes, and the following day you say, can I add on a Coombs test? And you can do that without any kind of compromise. The other thing is that prior transfusion may lead to a false positive because you're transfusing foreign red cells, which the body might actually mount a response to. And you'll see red cell autoantibodies, but they're actually not the patient's red cells. So it's not an autoimmune disease. It's an appropriate response to foreign red cells in the system. Does that make sense? Yep. Okay. And then I've just thrown this in, as I said, because we're looking at a smear under a slide. You sometimes trying to differentiate bleeding from hemolysis, and you've got a dog with a fever and unwell. Essentially, this is what platelets look like under a microscope. Sometimes they're a little bit smaller than that. If you've got platelets that are the same size or bigger than red cells, then your body is trying to produce more platelets than usual, or they're a Cavalier King Charles or cross of the Cavalier King Charles. If you're looking under a microscope, the basic rule, if you're on 100 times, is if you're seeing 1 platelet per high power field, that correlates with 10 platelets. So you can kind of times it by 10. So if you want to send out your blood sample and you're not going to get your platelet count for 24 hours, and you have a look at a smear in-house, so the published you're looking at your sort of high power fields, and I usually look at 10 high power fields and count the number in 10 high power fields to get a bit of an average per high power field. And I use 1 times 10. Some people use 1 times 15 and 1 times 20, but I actually think it's really dangerous to overestimate the number of platelets you have. So I use a low estimate. So if I'm looking at a smear, I'll see maybe 2 platelets per high power field on average. I'm going to times that by 10, and I'm going to say I've only got 20 platelets. This dog's in trouble, high risk of bleeding. We should have bleeding as a cause of anemia in this patient, as opposed to IMHA or hemolysis. All right, back to Ruby. So we said that her EDTA was noted to be auto-agglutinating. So she's met one of the criteria without any testing, without us even sending any blood to the lab or doing anything. She's met actually one of those criteria of saline agglutination tests. Sorry. So she's got some evidence of IMHA. She's met one of the criteria of immune-mediated destruction. And then she also, on sort of spinning down her sample, had yellow serum, hyperbilirubinemic serum, and she had spherocytes on her smear reported by the lab. So she's got mounting evidence of IMHA. She's a pretty slam dunk. So we've gone through the signs of immune-mediated destruction. Now we're going to go through these signs of hemolysis, which is just basically demonstrating that there's increased red cell turnover. The hyperbilirubinemia, we all know that there's a lot of different causes of hyperbilirubinemia. Josh, sorry. What are the causes of hyperbilirubinemia? Just broad categories.
Hepatic disease or red cell breakdown. Probably the main 2 that come to mind. It's a byproduct of heme, so anything breaking down red blood cells or anything not being processed by the liver would create hyperbilirubinemia.
Absolutely. And what do you see when your icteric patients? What's the most common presentation you would see?
Jaundice? Do you mean or?
Yeah. So what disease process causes jaundice most commonly in practice?
I think it is IMHA.
Yeah, it's probably pretty close. The other category that there is post-hepatic, like cholestasis, so post-hepatic biliary obstruction. So it is technically a hepatic failure, but it's post-hepatic obstruction that causes the hyperbilirubinemia. So I just divide it into pre-hepatic, which is only hemolysis. That's the only thing that causes it, as you said. It's a byproduct of heme. Then hepatic, because it's not being processed properly and we get a kind of a backlog building up. And then post-hepatic. So pre-hepatic or post-hepatic as my causes of hyperbilirubinemia. And that's kind of one of the reasons to do an ultrasound, because you can have a look at the liver, you can have a look at the gallbladder and bile duct if it's obviously obstructed. It's not IMHA as your cause of jaundice. So the recommendation from the consensus statement is to rule out other causes of hyperbilirubinemia. So liver function tests or just blood tests. If the ALT is normal, then don't worry about it. and rule out an obstructive cholestasis. The other interesting differential, which we don't really understand why it happens, is sepsis, but particularly cats tend to get hyperbilirubinemia when they're critically unwell. It's maybe because of decreased hepatic function, but we don't really understand it, or hemolysis for that matter. So the criteria to kind of diagnose hyperbilirubinemia is obviously increased bilirubin in blood, but also bilirubinuria of 2+ or more in the urine, or if you can see icterus, that they're obviously hyperbilirubinemic. There's nothing else that really causes that. I think it's really valuable in these patients, you're doing in-house PCVs, to stick the PCV tube onto their chart each day so you can monitor whether it's progressive or resolving, the degree of hyperbilirubinemia, or hemolysis for that matter. So you've kind of got the serum stuck as a nice little visual tool to see how things are improving. So the next criteria to demonstrate hemolysis is the presence of haemoglobinaemia or uria. And that's a little bit tricky because in these patients, often we're taking blood from peripheral veins, so it's taking a little bit longer, we're taking it through a smaller needle. And often red cells can get damaged on the way into the tube. So always with haemoglobinaemia, I try and make sure we're taking it from the biggest needle possible if I'm suspicious and want to be monitoring it. And that it's processed in a timely fashion without accidentally being frozen. Or if there's lipemia, then I won't kind of read too much into the haemoglobinaemia because that will break down the red cells just in storage. And we also want to make sure it's not myoglobin. And this is really interesting because the CK is not part of a normal panel in most in-house biochemical profiles. So often we're sort of getting these haemoglobinemic patients and then we do a CK and their CK is off the charts and they're actually myoglobinemic or myoglobinuric. So really important, if you're seeing red serum, add a CK to your panel. Just make sure that we're not missing muscle damage as opposed to red cell damage. If you've already got an anemia, it's not as much of a mystery. It's pretty clear that it's going to be haemoglobinemia. If you're seeing hemoglobinuria, it's really important to differentiate whether it's red cells or whether it's actually the hemoglobin in the urine causing the red discoloration. And the best way to do that is just to spin down a urine sample, because if it's hemoglobinuria, the urine will stay red, won't change. If it's red cells in the urine, the red cells will sediment out to the bottom and your supination on top will be clear. There's a couple of sort of false positives and stuff with different urine tests, but it's not so important. Is anybody interested in knowing why some of these IMHA patients are hemoglobinemic and some of them are not? Yes. Yes? So if I see hemoglobinemia, I'm really worried that this is a really serious IMHA. So it tends to occur in the more aggressive IMHAs. There's two different types of IMHA. There's intravascular IMHA or extravascular IMHA. And what that refers to is where the red cells are being broken down. So either within the vascular space or outside of the vascular space. By far the most common, like 9 times out of 10, it will be extravascular, and the red cells they've got their antibodies on the surface and they're going through the spleen and they're being broken down in their spleen, so in the extravascular space. The other 10%, the red cells have got the antibodies on the surface and it's actually complement in circulation mediating that red cell destruction. So a complement, we learnt about it for like 20 seconds at uni, and it's just been one of those mysterious words that we kind of shows up in textbooks. Does everybody know what complement is? Sort of. Not really.
20 seconds would be about right.
Yeah, I think that's about all I've got as well. But essentially, it's a part of the immune system which has the capacity to detect antibodies on the surface of red cells and actually punch holes in the cells. So it just kills cells. That's its main job. So most of the time it's targeting infected cells, and it just, if there's infected cells in circulation, it just goes around punching holes in them and all the contents ooze out and the cell dies. So complement, like if you've got destruction of red cells in circulation, there's a lot more complement and a lot more capacity for destruction with complement than there is with relying on the spleen to take them out. They've got to go through the spleen and then go through again, and I take a little bite out of them each time. It takes longer for red cell destruction to occur. Whereas if complement's destroying them inside the vascular space, it just punches a hole in them, all the hemoglobin leaks out, you end up with haemoglobinaemia. Whereas in the splenic destruction, you end up with hyperbilirubinaemia. So yellow for extravascular, red for intravascular. If I see haemoglobinaemia, I'm concerned that it's a really rapidly progressive, aggressive IMHA. And the only dogs I've ever seen die of like thromboemboli, arterial thromboemboli, have been ones with haemoglobinaemic serum. Does that make sense? Do you want a picture, or is it extravascular, intravascular clear?
Clear.
Yeah, cool.
Thanks.
So if I see this in clinic, I am throwing cortisone and cyclosporin and any immunosuppressant we can get to basically at these patients, and anticoagulants. So the last criteria for documenting that there was red cell breakdown are these erythrocyte ghosts. And essentially they're red cells that the contents have leaked out of. So they're dead red cells just floating around. But it's happening at such a pace that the body can't either reabsorb those membranes yet, or it's happening sort of so frequently that it's sort of, you know, that red cell just died and we've taken the smear right now. And these are something that you can see in a smear in house, and also if you're sort of writing on your history on your pathology form looking for evidence of hemolysis, then your pathologist will comment on them as well. So Ruby had autoagglutination, she had spherocytes, she had no hemoglobinuria, but she did have a hyperbilirubinaemia. So now we go on to what testing I recommend in patients that I'm suspicious of IMHA, or patients that I've got a slam dunk diagnosis of IMHA just based on clinical signs and a CBC, and a saline agglutination test. So I do like to look for underlying causes of IMHA, particularly if I'm suspicious of an infection. So if I've got a sort of tachypnea or there's urinary tract signs, I will look for causes of infection with chest radiographs and a urinalysis. I don't bother with a Coombs test if I've met the sort of two criteria. So if I've got autoagglutination and spherocytes, but if I haven't got spherocytes or I haven't got autoagglutination, then I will do a Coombs test. And in cats, I always do a mycoplasma PCR, just because cats are so much more likely to get red cells. And if anybody's listening from not Sydney local, there are a lot of red cell pathogens. We just don't see a lot of them here. So any testing that's specific for your area. Abdominal ultrasound, I think it's good to do, but I think it's really hard to interpret in an acute process like this, both in IMTP and in IMHA. So often these patients are becoming acutely anemic. Often they have splenomegaly. Often that spleen has nodules in it because they're using every tool in their belt to produce red cells. And we get a lot of extramedullary hematopoiesis, and you can't really interpret that in a patient that's sort of acutely unwell, and particularly thrombocytopenic patients, when you have no opportunity to take samples because it would be dangerous for the patient. So often I find the ultrasound raises more questions than it does answer. But certainly if it's not a slam dunk autoimmune disease and you're looking for causes of bleeding, or particularly melena, if there might be a mass or something there, then abdominal ultrasound is not going to do any harm. Where I think ultrasound does do harm is if the patient's not adequately sedated or stressed and thrashing around and thrombocytopenic. And we quite often see thrombocytopenic patients who've had ultrasounds whose entire abdomen, the entire clipped patch, you can see where the probe's gone. So it's just caused such significant bruising, running the probe over the abdomen with any sort of pressure. that in IMT patients I often sort of wait, you know, if the owners are super committed and happy to go ahead with treatment anyway, I just sort of say, let's do the ultrasound next week once we're stable. Let's just prioritise getting stable before doing it. And sort of the same thing with chest rads. Make sure that they're adequately sedated, that they're not thrashing around, banging their head and things with IMT. I just think these patients are so fragile. It doesn't actually usually change anything that I do, the abdo ultrasound or chest rads. So it can always be done down the track. So Ruby's met all my criteria, essentially. So she's Coombs positive. She already had the autoagglutination and spherocytes. So that was just a nice little kind of feather in the hat. And she did have splenomegaly on ultrasound as well.
And it's worth another criterion is the breed in Australia, which is different from what are listed in North America.
Absolutely. That's a really good point, actually. What do you think, what sort of breeds would you say are most predisposed in Australia?
But terriers like that, or little or white fluffies.
Absolutely. Yeah. So there's a paper out of Melbourne which looked at the different populations of dogs that are affected. And because we're talking about genetics as a predisposing factor, the dogs out of Melbourne probably almost doesn't apply to the dogs out of Sydney, because there's so many breeders using different genetic pools with dogs that are kind of common. But we certainly see more Maltese and small fluffy crosses than are reported overseas. The classic breed, which this is a really good point, Jeff, but Cocker Spaniels get such severe intravascular hemolysis, as do Border Collies. They're the two that I would say get them. If I sort of see either of those two breeds come in anemic, particularly middle-aged female, I just hang my head, because they're the ones that they relapse, they're on immunosuppressants for life, they have clots. I've just had bad experiences with these patients. Has anybody else had those breeds? This is definitely ones to look out for. So we're moving on to treatment, and the consensus statement just says that the most important thing you can do is do not delay starting cortisone. So get all the samples you need as quickly as you can, but you need to start cortisone as soon as possible. So any results you can get in-house, like your autoagglutination, your smear, and sort of, you know, biochem and stuff like that, absolutely do it as quickly as you can. The dose of cortisone is a little bit controversial, and there was a little bit of disagreement amongst the consensus statement on what to start on, because often these dogs are sort of acutely unwell. They're going to be on medications for 3 to 6 months. The prednisolone has to be sustainable and can't cause terrible side effects. For me, a dog less than, this is the consensus statement, so it's not just me, but a dog less than 25 kilos, I would do 2 to 3 milligrams per kilo per day, divided into 2 doses. Traditionally, there's a lot of published data saying 4 milligrams per kilo per day, but they looked at the evidence in this consensus statement, and there's actually no evidence that greater than 2 milligrams per kilo per day makes any difference to outcome, and obviously comes with a lot more side effects if you're doubling that dose. Then any dog greater than 25 kilos, I drop way back and don't use a milligrams per kilo dose. I use a meter squared dose, and I actually cap. I will never go above 60 milligrams of prednisolone per day per patient, and I'll divide that into 2 doses. I don't feel like we get any extra benefit, and I feel like I've euthanized patients because of prednisolone side effects. You know, I've had patients that were so weak that they could barely stand and things, particularly older patients with underlying joint problems and things. I'm a little bit more conservative with my prednisolone. This I found really handy to have kind of in the back of our mind when to just start prednisolone and when to start an additional agent, an additional immunosuppressant right from the beginning. So that the prognostic factors were increased uria or increased total bilirubin is associated with a poorer prognosis. So if you've got either of those, you've probably got more aggressive IMHA, and you probably need to be more aggressive about getting on top of it. So, because you're going to be treating for longer and potentially lifelong in these patients. If the PCV has fallen by greater than 5% over 24 hours in the first 7 days, then, so if you've sort of started, you've got a patient in hospital, started on cortisone, done a PCV the day after, and their PCV's halved, then they say add in another agent at that point. This can be really difficult because often we're transfusing them in this time, and it can be difficult to judge whether the PCV is falling or whether it's, because we're boosting it up. But certainly if you've got ongoing losses, start a second agent in that first 7 days. If you're still doing blood transfusions beyond 7 days after starting prednisolone, and I actually use 5 days, that's my cutoff, because that's when I like to see pred kicking in. Or if they're greater than 25 kilos of body weight and a high risk for side effects. So for example, even if I've got a 19 kilo staffies just melt on pred. I think you've probably all experienced a staffy with its concave temporal muscles, and it can be pretty traumatic for the clients, and you know how noisy they are all the time anyway. If you increase panting, it can be quite traumatic for everybody involved. So certain breeds and high body weight, I always add a second agent in just as a pred sparing effect. Does everybody kind of agree with that, or doesn't anybody have any strong opinions about that? Not really? So as far as what second agent to choose, this is where I think there's the most controversy, and basically the consensus statement is do whatever you're comfortable with, do whatever you want. There are certain breeds that azathioprine doesn't work as predictably in, that include Schnauzers, Malamutes, and Dobermans. However, that wasn't a contraindication for using it in the consensus statement. Jeff, what's your drug of choice?
I've usually gone with azathioprine, but not for any real reason. Just it's more tradition than knowledge. And the consensus statement only came out, I think, beginning of last year, didn't it? So,
yeah, exactly.
I'm wondering. I think Liz tends to use cyclosporin more often. So yeah, that's another thought.
Absolutely. So I actually use azathioprine as a first choice most of the time because it's more sustainable cost-wise. And then I get a dog that gets a hepatotoxicity, and then the next patient I tend to use cyclosporin as the next choice. Most of the time with azathioprine, I start them on it. The most important thing with it is that you reduce the dose to every other day. So you load them with azathioprine, and you have to reduce because they will become myelosuppressed or develop hepatotoxicity if you don't. So there's a sort of, in referral medicine, there's a lot of people that want to get back to their regular vet, and a lot of vets that want them back to their regular vet sooner before this. And if I'm not in control of this part, I will start them on cyclosporin, because it's so much, just making sure that dose reduction happens. If it's kind of somebody else's case, it irks me. And we have had patients that weren't reduced as they were supposed to and have come back with terrible myelosuppression as a result. So that's the main thing that concerns me about azathioprine. Whereas cyclosporin, you start at that dose, you stay on that dose basically until they're off prednisolone. Cyclosporin doesn't work at doses under 5 milligrams per kilo BID. So there's been studies that looked at efficacy, and it just doesn't work at all. In my hands, I think I get dogs vomiting or having diarrhea on cyclosporin at least 50% of the time if I don't freeze the capsules. So that's a really hot tip as far as getting them on a medication that they can keep down. Cyclosporin causing vomiting in that frequency of patients, if they're thrombocytopenic, vomiting is very traumatic on the gastrointestinal tract, and it could trigger a bleed. If they're IMHA or thrombocytopenic, you're giving them medications that they then vomit up again an hour later. They're not getting their full dose of immunosuppressant that they need to stay alive. So anything that triggers vomiting, I am nervous about. So I do tend to go for azathioprine first, as long as I can kind of control its weaning. But then there are cases that I'd use cyclosporin, as I said, and particularly if the capsules are frozen, because much less like they're absorbed more slowly. The kind of nausea effect is because it is absorbed really rapidly and it causes this sort of acute onset nausea, whereas if you give it frozen, it's absorbed more slowly. They don't get that big kind of after dosing, and they're less likely to bring their medication up, which is important. The other thing about cyclosporin is that it's hideously expensive, particularly in large breed dogs. It's just cost prohibitive in a lot of patients. So for that reason, again, I often go for azathioprine first, just because of trying to look after the owners, because there'll be a lot of monitoring and blood tests down the track for these patients. Mycophenolate is one of my new favourite drugs, actually. Mycophenolate mofetil, it's pretty readily available from pharmacies. It's actually a little bit cheaper than cyclosporin if bought from a pharmacy. So obviously cyclosporin veterinary brands are more expensive than the oral, which is what we normally get from a pharmacy. But yeah, mycophenolate, it acts in a similar way to azathioprine, but has less hepatotoxic and gastrointestinal side effects, and virtually no myelosuppression. So I'm pretty fond of that. It can cause vomiting as well, but in patients that tolerate it initially, they tolerate it long term, whereas cyclosporin, they can get vomiting kind of down the track. The interesting thing about mycophenolate is that it works in the same pathway as azathioprine, as does a new immunosuppressant called leflunomide. So there's absolutely no point giving, or you'll get toxicity if you give azathioprine with mycophenolate, or azathioprine with leflunomide, or leflunomide and mycophenolate together. So those three kind of cancel each other out. It's one or the other for those. Interestingly, in the consensus statement, they've said not to exceed 2 immunosuppressant agents, which is interesting because we do often end up with a patient on 3 immunosuppressants, and certainly something that they said was consider splenectomy once stabilised if you're sort of having to look at doing a third immunosuppressant agent because you're not on top of it. Consider taking the spleen out in these patients, because obviously if it's extravascular hemolysis, that's where the blood cells are going. You take it out, you take away part of the problem.
Even if with the high doses of pred, like those kind of.
Yeah, so often the splenectomy would come, so we can usually get them out of a crisis with these medications, and then we get them up to sort of an IMHA and hematocrit of 25, and then we just can't get them any further. So we've just got still spherocytes and like on the blood smear review, and still signs of active hemolysis and immune mediated destruction, and then we sort of have to say, okay, we're not winning here. What's our next step? So these medications will usually get you out of a crisis. I've put vincristine on here for IMTP. I don't use it routinely because it's got gastrointestinal side effects again, which might trigger a bleed. And also the studies on how effective, so vincristine increases numbers, and dogs will get out of hospital around about 24 hours sooner if they're admitted for IMTP. If they're given vincristine on their first day, they get out of hospital sooner, but they're discharged because their platelet number goes up, not because they've got adequate clotting capacity. So the sort of labs that I worked with in America analysed the efficacy of platelets in dogs that have had vincristine, and those platelets don't work very well. So we feel better because their platelet number's okay and we send them home, but actually there's not any data looking at whether they had more or less likelihood of bleeding. So I don't use vincristine because of the GIT side effects, but Liz and Dave both do, so there's no right or wrong. And my hesitation is that I don't think the platelets work, but it feels really good on paper to see the platelet numbers coming up. And the last thing we'll go through is how I wean these patients. So I want to get their PCV up to 30% on their own without transfusion for greater than 2 weeks before I start weaning. The only exception to that is if they're having terrible side effects from one or the other of the medications, in which case I'll either switch out that medication or wean it sooner. And the recommendation is just to reduce prednisolone by 25% every 3 weeks. So that first one is a big drop, and then obviously 25% of a lower dose gets lower and lower and lower for a long time. We aim for a total treatment course in kind of uncomplicated middle-aged dogs of 3 months. In the more complicated patients who have kind of underlying diseases that we're not sure triggered it, or if they had particularly aggressive, like intravascular hemolysis, I will treat them for 4 to 6 months. Usually I do 3 months of prednisolone and then 6 months of the other agent, which has lower side effects than prednisolone. The consensus statement, sort of, you wean prednisolone for sure, but there's no evidence to say that you need to wean cyclosporin, azathioprine, or mycophenolate. Most of the panel said, oh, we just stop cold turkey. And then another sort of 30% of the panel said, oh, I like to just halve it and then stop, which I guess makes more sense to me. I'm more comfortable with that. So I do tend to wean over the last month of treatment my additional agents as well. And I think that's all we've got time for. I hope that was helpful for anybody managing these.
I had a little terrier once, and it took over 12 months before I could take him off immunosuppressives.
This is what I'm dealing with my hospital patient at the moment. We're literally 16 months and he's been on immunosuppressants the whole time. And we put him on pred and took him off cyclosporin, and he's relapsed and developed IMT, and he's still on, what is he on? He's on, 5 mg per kg of cyclosporin BID, and he's relapsed.
You didn't mention aspirin or clopidogrel.
I really should have, actually. Yes, sorry. So that's part of my treatment in every single IMHA patient. I will start them on anticoagulants. If they can tolerate oral medications, that's preferable. We get a combination of both venous clots and arterial clots in IMHA. So just context why that's important is venous clots we treat with factor inhibitors like Fragmin or heparin, whereas arterial clots are better prevented with platelet inhibitors like Plavix or aspirin. Certainly the studies say that clopidogrel or Plavix is superior to aspirin with lower side effects, less risk of GIT bleeding, less risk of renal impact. So clopidogrel is every single patient goes on it. And then if I'm particularly concerned, so if it's a border collie, Cocker Spaniel, or it's got Haemoglobinaemia, then I will often put them on a factor inhibitor as well. And I'll either use injectable Fragmin, the factor 10A inhibitor, which is injectable TID for our hospitalised patients. But there's a new oral factor inhibitor called rivaroxaban, which I'll often put dogs on, and cats, in fact, if they've got like a high risk. I'll put them on that in conjunction with clopidogrel. The only downside is it's a lot of medications for the owners to do. So in these ones, I often sort of get a pill box and do the first week for them so that there's no kind of risk of confusion. Obviously, it's difficult to monitor any anticoagulants, so it's hard to know whether you're sort of putting them at risk, but we've never seen clinical bleeding in these patients. IMT, I don't tend to anticoagulate. It makes me too nervous.
Anna, can I ask you a question? With the azathioprine, you know the hepatotoxicity is supposed to be reversible if you stop the drug. Is that the same with the bone marrow suppression, or can that be permanent?
It should be reversible as long as you don't wipe out the bone marrow. So if that dose goes for long enough, you will get stem cell suppression and death, and you'll get myelofibrosis. So do you remember Maisie Abbott?
Yes. Tony Abbott's dog.
Yeah, yeah, exactly.
Yes, I had to see him.
Yeah. So Maisie got azathioprine-induced myelosuppression, and it took her months to grow back cells. And she got, in that time when she was immunosuppressed and myelosuppressed, she got that cholangiohepatitis bacterial.
That's right.
Was the end of her.
And my other question was with the mycophenolate. I was reading that they quite often get sort of really intractable diarrhea in about 20% of cases. Have you come across that? And is that treatable, or does it go away if you stop the drug, or can that be a big issue?
There's two different forms of mycophenolate. There's mycophenolate sodium, and mycophenolate mofetil.
Mm-hmm.
And gastrointestinal signs are much more common with the sodium compound of it.
Okay.
I haven't experienced patients with diarrhea. I've had patients vomiting, but not diarrhea with the mycophenolate.
Because it's a lot cheaper, isn't it, than cyclosporin?
Particularly if clinics are happy to write a script and have the clients source it themselves, you can get it a lot cheaper. And I find the dose, often with cyclosporin, we're having to get them to give 100 milligram capsule plus a 50, or I think the tablets that are dividable, and they're much more kind of just cost effective.
Okay, cool. Thank you.
No worries. The only downside of mycophenolate is you can't give it with omeprazole, which obviously in a lot of our IMT patients, they're bleeding, got gastrointestinal bleeding, and we really want them on omeprazole, so that would potentially impact.
But do we though?
Well, we probably shouldn't have them on omeprazole. You're right.
Because didn't the consensus say no omeprazole in ITP?
It did actually say no omeprazole, but then the dogs.
But we still do it.
I actually don't. I usually don't, but it's if they've got a whole heap of melena in an IMT patient, I probably would.
And the other thing I read the other day is if you put them on, a lot of people put them on omeprazole when they are on a high dose of steroids. Apparently that gives you an increased risk of GI side effects, which is interesting.
It is interesting. Was that in the antacid consensus?
No, I don't think it was. I think it was somewhere else I read that. I'll have to find the reference. But they did a study where they looked at it with the, dogs on high dose pred with omeprazole or no omeprazole, and there was more GI side effects in the omeprazole group.
Interesting. Because so theoretically, omeprazole is excellent for treatment of gastric ulcers. It actually predisposes to development and exacerbates duodenal ulcers. So you've got melena and you go omeprazole, but actually you need to do a scope to work out whether it's indicated or not. But it's so impractical in our patients that we often just makes us feel better to do something, but we'll probably be better than nothing.
I'll have to find that link.
The other thing to consider is long-term antacids can predispose to pneumonia.
Oh, really?
Yes, because, in man anyway. So I think the reason being that the stomach acid is an antibacterial for the rest of the gut sort of thing. And of course, if they're on high doses of pred, that wouldn't be a good thing to precipitate. But I think it's only when used long term, like many months, like as humans might be.
I've got a talk on antacid use. We could schedule that for the next one if you're interested. Alrighty, we might wrap up. Thanks so much for coming, everybody.
Thanks, Anna. That was great.
It certainly was. A lot of very practical tips there. Thank you.
So if next will be Alan on Monday, surgery for Monday evening, and then Mariano's rounds is actually moving to 8 a.m. on Tuesdays now from next week. So I'll send out a reminder about that. And I'll see whether I can post these papers. I don't know whether there's restrictions on me sort of putting a paper on our app, but I'll look into that and see whether I can get the consensus statements out to you. You can just Google them anyway.
Maybe even just as abstracts. You might be able to put those up.
Yeah. Good call.
I think you can, Anna, I think you're allowed to email them to people for personal use, but not like put them up for everyone to look at, if that makes sense.
Website. Okay, that's what I thought.
You can put up a link.
That's a good idea because it's free access anyway. That's a great idea. Okay, thanks guys.
Cool, thank you.
Thank you, bye.